I'm Charles Bankhead of MedPage Today, reporting from the Genitourinary Cancer Symposium in Orlando. In what some oncologists are calling a landmark clinical trial, intermittent androgen deprivation therapy demonstrated non-inferiority to continuous therapy in a large randomized clinical trial involving men with non-metastatic prostate cancer. Dr. Lawrence Klotz of Sunnybrook Medical Center and the University of Toronto describes the key results that came from this study.
The patients were randomized between continuous hormonal therapy with flare blockade and intermittent therapy, which was 8 months of treatment, stopping treatment if they had a response, which most of them did, resuming treatment when the PSA got back up to 10. So in a nutshell, what we found is, first of all, patients on the intermittent arm spent most of their time off therapy. Less than 30% of the time was actually on treatment. We found absolutely no difference in overall survival between the two arms. The curves are superimposable. We did find a trend, which was not significant, to somewhat more prostate cancer deaths on the intermittent arm and somewhat more non-prostate cancer deaths on the continuous arm. Essentially, that they canceled each other out. Was about 8 or 9% in both directions. And the significance of that is something that we're going to be debating for a while. But I think the key point is that if in fact there is a small benefit from disease control perspective of continuous therapy, it's canceled out by the increased cardiovascular risks of the hormonal therapy. The other thing that really supports the intermittent approach is we saw a statistically significant improved time to androgen-independent progression on the intermittent arm, which is very important because it supports the original hypothesis that by re-exposing cells to androgen, you could prolong the time to androgen independence.
The results could finally bring to an end a clinical debate that goes back 25 years or more.
So the concept goes back actually to the mid-'80s. As far as I can tell, the first guy to propose this was a patient of Willett Whitmore's at Memorial Sloan Kettering in the early 80s, who was an athlete and had metastatic prostate cancer, and the estrogen was interfering with his athletic competitiveness, and he said, why can't I go off this? And no one had a good idea. So that led to a group of about 20 patients being treated intermittently with estrogen. I reported those patients 25 years ago, and that was the first report of intermittent hormonal therapy. And then over the years, there's been close to 20 phase 2 studies, mostly reporting very good results showing that people can stay off treatment 50 to 60% of the time. And there's been about 8 phase 3 studies, mostly small. Our study was, first of all, much larger than any of the others. It was almost 1,500 patients. It had long follow-up. It had lots of events, and it was done very meticulously. And it was also on a homogeneous group of patients, that is, without metastatic disease, only with rising PSA after local therapy had failed. So I think this will be viewed as the pivotal study in this question, which is how to use hormones in the treatment of patients with biochemical failure.
In Klotz's opinion, the results establish a standard of care for the vast majority of men with hormone-sensitive prostate cancer.
Well, I think that intermittent therapy will become the standard of care for most patients going on hormonal therapy for biochemical failure. I don't say all, because going forward, there may turn out to be some groups who do benefit from continuous therapy. At this point, we can't identify those groups. All the studies show essentially that whether it's patients, other studies besides ours, whether patients have metastatic disease or not, they seem to do as well. So I won't preclude down the road some possibility of subgroups being identified who may do better with continuous therapy. But I think for the vast majority of patients going on hormonal therapy with non-metastatic disease, they should go on intermittent therapy. There's many benefits and really no downside to this.
Reporting from the Genitourinary Cancer Symposium in Orlando, I'm Charles Bankhead, MedPage Today.